So pericarditis, as you can tell from the name, is inflammation of the pericardium. Remember, there's actually, we said there's 3 layers of the pericardium, so let's change it to that. The fibrous layer, the visceral layer, the parietal layer. And etiologies of this inflammation include idiopathic, so it's probably viral, but we're not sure. It can be tuberculosis, radiation therapy can cause it, or cardiac surgery, because when you're doing surgery, you're cutting stuff up. And when you're cutting stuff up, that's damage, and with damage, you're going to get inflammation and healing. Clinical features of pericarditis. Remember, we covered this already in our differential diagnosis of chest pain, because you are going to get sharp chest pain. And remember, it's inflammation of that outer sac of the heart, so it's very positional dependent. It's worse with inspiration. It's improved by leaning forward. Inspiration puts it more into contact with the chest wall. Leaning forward puts it into less contact, so there's less irritation. And in auscultation, you're going to hear a friction rub. So that's very characteristic of pericarditis. Now, the EKG changes are important to realize, and I'm going to show you them first. And what sticks out to you? What blatantly jumps out to you on this EKG? If you don't know, that's fine. But what you should be seeing is ST elevations, and you're thinking, "Ooh, that's an MI." But if you realize, it's going to be diffuse ST elevations. You see ST elevations 1, 2. You see ST elevations in AVL, AVF, and that is because you have diffuse inflammation of the heart. So you get diffuse ST elevation, and you might also have some PR depression, PR interval depression. So now that's important to note, because they might show you this picture, and they might be wanting to trick you into thinking it's MI. But now you know. Now you're not going to get tricked, because you're going to see that diffuse ST elevation, and you're going to know it's pericarditis, because of this diffuse inflammation of that whole pericardial sac. Now, complications of pericarditis. Remember, the pericardium secretes fluid. There's a pericardial cavity in the middle. There's a serous pericardium that secretes fluid. And inflammation may cause it to increase its secretions. And so you're going to have increased fluid hanging out in that pericardial cavity, and that's called a pericardial effusion. Now, this effusion can develop into something called cardiac tamponade. We're going to talk more about that in a second. But tamponade is basically when you have too much fluid in that pericardial sac, and it's exerting a lot of pressure onto the heart. It's preventing the heart from expanding very well. And there's overall lots of pressure on all 4 chambers of the heart. The other major complication from this is constrictive pericarditis. Now we're going to talk about both of those. So let's get into it. Cardiac tamponade, we just talked about. What is that? It's compression of the heart by fluids. So we talked about effusions already. Another cause is from blood. If you have trauma, you're going to have bleeding that goes into that pericardial sac in between the 2 pericardial layers. And what's going to happen is, because you're having all this compression into the heart, you're going to impair diastolic filling of your ventricles. If you have impaired filling, then you're going to have poor cardiac output. Now, the clinical features, I don't know if you remember them. If you do, then try to think of them right now. If you don't, the clinical features are Beck's triad. You're going to get hypotension, because we just said there's poor cardiac output. You're going to get distended neck veins, because you have poor cardiac output, and all that blood is going to back up into your veins, and you're going to see that in the neck. And the final thing is you're going to see a muffled heart sound, because this fluid here, it's insulating. It's insulating the sound that comes from your heart. So that's Beck's triad, and it all makes sense if you understand the pathophysiology with the poor cardiac output and the fluid surrounding the heart. A couple additional features here. There's tachycardia. There's poor cardiac output, so then naturally tachycardia will follow. And then finally you have Pulsus Paradoxus. What is Pulsus Paradoxus? This is a fall in blood pressure, decrease in blood pressure greater than 10 millimeters of mercury during inspiration. Okay? So let's say you're measuring someone's blood pressure during expiration and it's 130. And then when they inspire, the blood pressure suddenly drops to 115. That is Pulsus Paradoxus. Now I want to explain this in it for a little bit. Pulsus Paradoxus is just an exaggeration of a normal phenomenon. When I say normal, I mean that inspiration will cause your blood pressure to decrease. Because, I need to draw this out a little bit. When you inspire, what happens to your venous return? Remember we said that venous return will increase because there's negative thoracic pressure. And your right ventricle is going to fill more, and it's going to have a larger size. So your right ventricle is going to get bigger. See, this is the right ventricle, right atrium, left ventricle. Increased venous return makes your right ventricle bigger. So now you see that the volume is decreased in the left ventricle. And if volume is decreased, then stroke volume is going to decrease, and thus blood pressure is going to decrease. And that is during inspiration. Now in tamponade, why does it decrease more than 10? Why is it exaggerated? Well, in tamponade, we have all this fluid around the heart. So now it's smaller than it normally is already. And then so when we inspire, we're going to pump out. And now this space that this septum is going to take is a larger proportion to the original volume of the left ventricle, because remember, it's all compressed already. So you have a proportionally larger decrease in blood pressure, and that's going to show up as more than 10 millimeters of mercury during inspiration. Other things that can cause Pulsus Paradoxus include asthma and COPD. And those cause Pulsus Paradoxus. Those are respiratory diseases. They exaggerate inspiration. You're going to be inspiring more. You're going to have bigger inspirations. And so you're going to have that super exaggerated response of this normal phenomenon. Hypotension can also cause Pulsus Paradoxus. And how does it do that? It's very similar to how cardiac tamponade does it. Because in hypotension, you're not going to have much blood filling up your heart. So again, you have a smaller heart. And so it's a proportionally larger decrease with that interventricular bowing. How do we treat cardiac tamponade now? So now we have a bunch of fluid in the sac. That's a problem. So the answer is we remove the fluid. Easy as that. And all you do is you stick a thin needle into this area and you aspirate all that fluid out. And that's called a pericardiocentesis. Okay, it's kind of like the pneumothorax, the thoracentesis, but this one is the pericardiocentesis. Alright, so now we go into constrictive pericarditis. So this is inflammation and fibrosis causing stiffened and non-compliant pericardium surrounding the heart. You can kind of tell that from the name. It's inflammation, so pericarditis of the pericardium, and it's going to lead to constriction of the heart because of that fibrosis. So it's like encasing the heart. And what you're going to get, again, is you're going to get impaired diastolic filling because you have this super tight, stiff wrapper around the heart, so it's not going to fill up anymore. And then again, you're going to get poor cardiac output. So what's going to happen? It's going to be similar symptoms. You're going to get your poor cardiac output, so the blood backs up into the jugular veins. You have increased jugular venous pressure. You're going to have the Kussmaul sign. Now the Kussmaul sign I like to explain as well. The Kussmaul sign is an increase in JVP during inspiration. Now normally, what would you expect JVP would react to during inspiration? Remember, inspiration will normally increase venous return to the heart, so there's more blood goes from the jugular veins into the heart, so the jugular venous pressure should decrease. That is normal. The Kussmaul sign is the opposite. You have an increase during inspiration, and this happens in constrictive pericarditis because that thickened myocardium does not transmit that negative intrathoracic pressure. So you get negative intrathoracic pressure around the chest, but not negative pressure inside the heart, which is inside the thorax, but it's not transmitted because of all that fibrosis. So your blood goes into the chest, but it doesn't go into the heart. So JVP will increase because you've increased venous return. to the veins in the thorax, but they don't get into the heart. So that's different. That's opposite of normal. Next, you have a pericardial knock. This is it's a heart sound that occurs earlier in diastole than the S3 heart sound, which is ready in early diastole. And then you can also have Pulsus Paradoxus, which I just explained. I just want to note though that Pulsus Paradoxus is much more common in cardiac tamponade than it is in constrictive pericarditis, because there's not as much bowing of the ventricular septum. So that's it for constrictive pericarditis and cardiac tamponade and pericarditis.